something. Someone needs to give me an answer so that I know maybe I'm not showing the right slide, or my cursor is not moving or something like that. Okay. All right. Like now. Okay, our first case. We are all anesthetists here in this session. Before I continue.
Yes, Doc.
Okay, I'll take that as a yes. Okay. All right. Our first case, you are going to anesthetize an old patient for an elective surgery. So a patient is coming in, 70-year-old is coming in for a laparoscopic cholecystectomy with ischemic heart disease. As they prepare and they interflate with the carbon dioxide, this is your ECG. So what is this, and what are your anesthetic concerns for this patient? Let us start with Kakamba. I will give you 1 minute. I'll give you 1 minute for everyone to think about it, and Kakamba is going to start for us. So we have an old patient who has ischemic heart disease coming for elective surgery. As they start, the surgeons doing their things. This is the ECG you see. What goes through your mind? What are your concerns when you see this? First, tell me, what is this? And then what are your concerns for this patient?
Hi, Doc.
Hi.
Okay, I can see that there's pathological Q waves in lead V1, V2, V3, and V4. So I think the patient has an ischemia over the anterior chest, over the anterior part of the heart.
Okay. What is obvious before you look deep? What's the other obvious thing? What's the heart rate? Yeah.
Okay, so I'd use the formula 300 and divide it by the big squares, which is 300 divided by 3. 1, 2, 3. So it's 100.
Okay. Is it in sinus rhythm?
Yes, it is. Okay, sorry. It is in sinus rhythm because looking in lead 2, there's a P wave preceding HQRS complex and in all of the leads.
Okay, all right. Okay. So this is, as you said, the patient is tachycardic. So this is sinus tachycardia.
Yes.
Sinus tachycardia in a patient with ischemic heart disease. What is your worry?
Okay, so if a patient is having tachycardia, it means that there might be decreased perfusion to the coronary circulation because there's not enough time for diastole. So there's not enough time for blood going into the coronary circulation.
Yes, yes. So that is one of your pages. Sorry. So that is what I want you to guys to pick up from this. This is not a, how do I put it? Not a drastically so abnormal ECG as you guys might be looking for, but this is a sinus tachycardia in a patient with ischemic heart disease. So that means there will be imbalance in the oxygen supply demand to the heart. So you should worry about that in this patient because the patient already has ischemic heart disease. like you said, now there will be decreased perfusion to the heart. So unfortunately, a lot of people, when they put people to sleep, they're always under the impression of, as anesthetists, our job is to get the patient off the table, of which, you know, as anesthetists, our greatest job is not intraoperative care, but it includes perioperative care. So if your, I'll use a bad word, if your anesthesia is shady on the table, you might impose complications on the patient that might be detrimental to the patient in the long run. So this patient might get a perfect laparoscopic cholecystectomy, but this patient, the 70-year-old, might die in the next 15 days just because of maybe you didn't pay attention to subtle things like this, like oxygen supply to the heart. So this is a patient with sinus tachycardia. Your worries as an anesthetist is what Kakamba was describing, perfusion to the heart, except other things that we won't go into. So I just wanted to start with this before we go on to other ECGs, just to, whenever I teach an anesthetist, I always try and implement this principle that when you anesthetize a patient, don't only concentrate on just doing things to get the patient off the table, but pay attention to the perioperative care of the patient. Yeah, we're going to move on to the next slide, but maybe before we do that, let's slightly talk about the exam. So mostly how we're going to go through this session, that's how, in terms, we're talking about ECG now, but that's how the exam is structured, in terms of you're not given something where you're going to have a paragraph of an answer. You're going to answer in point form, and it's going to be a straightforward, give a diagnosis of this, and then how would you manage? Or what is the diagnosis, and then what are your concerns with that diagnosis in this patient? All right, we're going to move on to the next slide. Thank you, Kakamba. So your anesthetic concerns, if we're going back to that, the patient could be still light in anesthesia, so you want to look into that. There could be stimulation of visceral pain pathway. Maybe that's why the patient is tachycardic. Maybe the patient is tachycardic because of carbon dioxide absorption. But your greatest concern is what Kakamba mentioned, that this is a patient who's a cardiac for non-cardiac surgery. So there's a risk of major adverse cardiac events or myocardial infarction after non-cardiac surgery. So things to think about. Okay. This is our next one. You have an 82-year-old for anterior resection for a rectal CA. So this is your ECG. You go and see your patient in the ward for your preoperative evaluation. The patient is coming for big surgery, which is semi-elective surgery, and this is your ECG. So what is the diagnosis? If there's no volunteer in 30 seconds, I'll call out a name.
Hi, Doc.
Hello.
So we'll start with the rate.
You don't have to interpret for me, just give me your diagnosis.
Oh, okay. I think it's a morbid type 1 heart block, AV block.
Okay. So it is a heart block, but let's go through it again. Is there correlation between the P wave and the QRS? Look at it again. So take a V2.
Okay. Yes, some of them, there is a correlation, but I see that the PR interval keeps increasing, and then there's a drop of EQRS. So the PR interval keeps increasing, and then there's a QRS drop.
Okay. Remember, with the type 1, with the drop, so it keeps on increasing, and then there is some regularity to it. So the PR interval will keep on increasing, then there's a drop. And then the PR interval, when it starts again with the type 1, it starts as normalish and then keeps on prolonging. You see the pattern I'm talking about. So it keeps on, it starts at a certain millisecond, then keeps on prolonging, then drops. And then when it starts again at what it had started there, then keeps on prolonging. Do you think the same thing is happening here?
No.
Yeah. So if you look at it, this one, there's no correlation between the P waves and the QRS complexes. Because there's one where if you follow lead 2, there's one where you actually see where it looks like there are even 2 P waves.
Yes.
If you look at the one, I'm not sure if you can see my cursor. If you look
Yes,
at this one in the middle, there's a P wave there, then there's a P wave, and then there's that QRS, then you assume that's a T, and then there's no correlation between the P and the QRS. So that is a complete heart block, so a 3rd-degree heart block. So what is then your plan? If you see this patient and the patient is coming in for tomorrow, would you continue? Okay, would you continue? Would you anesthetize this patient?
No, I wouldn't continue the case.
Okay, why?
Because I think the patient needs optimization, so I'd send for a cardiology consult. I
For
think
what?
for a pacing, I think patient might benefit from pacing.
Okay. So the patient is coming for semi-elective surgery, so it's not urgent, and the patient needs to be paced. Let's say this was urgent. What do? You call Dr. Ndlovu, but what else would you do?
I think we can try percutaneous pacing.
Okay. So remember, anesthetic is a perioperative physician. Yes, with a cardiology consult. So the proper way to answer it with a cardiology consult, if it's urgent, you would consider percutaneous pacing from our side. But the point I wanted to bring up is that, yes, this is elective surgery, so this patient needs a pacemaker. So you discuss with the cardiologist, like you correctly said. But remember, most things that will come for the exam, it's usually something where it's an urgent case. Then what do you do? So you need to be able to have a plan for an emergency setting. And going into pacing, just look, hopefully maybe we might have another session where we do a mock exam session, but if we don't, just look how to identify a pacemaker on a chest x-ray versus an ICD, because it's slightly different, how they appear, the machinery. So just know how to differentiate between the pacemaker and ICD. And then all the questions then that will come with a pacemaker and ICD, what would be your anesthetic consent? So look into that. Okay. So as you said, this is elective surgery with complete heart block, needs to be referred to a cardiologist for insertion of a pacemaker. So I'm sure most of you know this diagram, but you need to be able to differentiate between the two. So with a first degree heart block, it's constant prolongation of, so it doesn't change the interval of the PR interval. And then with a second degree, there's type 1 and type 2. And then with a third degree, it's what we talked about, that there's no correlation between your P waves and your QRS complexes. Okay. Again, you're going to go do your preoperative evaluation on a patient, and then this is the ECG you see. A 60-year-old patient coming in for some elective surgery. This is the ECG you see. What's your spot on diagnosis?
Irregular rhythm, so I would go with atrial fibrillation.
Okay. Let's look. Are there P waves?
Oh yeah.
Look at lead, what's that lead? Lead 1. Are there P waves?
There are P waves in lead 1.
Mhm. I do get you. Some of the, like look in V5, there are P waves there, but small voltage.
Not P waves.
But there are P waves. Look there in V6, there are P waves,
Yeah.
but small voltage. Look there, V4. Okay. What is this? What do you call this?
Let's see.
This one. You can see my
Would that
chest
not
there.
be? Yeah. Okay, will that not be a QRS complex?
Yes,
really
from
not.
where? From where? Look at this. We have a P there. I know it's a small P. We have a QRS, we have a T. And then we have this. How is this different from this when you're looking at it? So what does that tell you? Where are these from?
Is it not a PVC?
Premature ventricular contractions?
Yes, these are premature ventricular contractions. You can see they're broad and they have that slurred at the so they're broad, so they're and you see they don't have a P. They don't have a P. That's how you know they are ventricular. They don't have a P. I think and some people might think this is a P. This is actually a T from this QRS complex. So these, if you look at them, And here you might think it's a P for this complex, but it's not. It's actually a T of this complex. So these are premature ventricular contractions. So they're ventricular in origin. So you should always be able on an ECG to tell, is this from the atria or from the ventricle? Because if it's atrial in origin, it will be narrow. If it's broad or wide in origin, it will be a bit wide, which helps you in diagnosing a lot of arrhythmias. Let's say the same patient, you take the theater, the patient, you saw the patient like this in the ward, patient hemodynamic stable, no issues. These were not these regular, these premature ventricular contractions were not so regular in about 10 minutes. And then you take the patient in, and then the patient intra-op changes into this. So what is this? What's your spot on diagnosis? And how would you manage it? Let us have Ayanda.
Hello.
Hello.
I'll take a guess. Is it not a ventricular fibrillation?
Okay, let's explore that. Why do you think it's a ventricular fibrillation?
Because on almost all the leads, there's like a, how do you call, like a saw kind of appearance.
Okay. Dineo, can you help Ayanda?
Hello.
Hi.
Yes.
Call a friend.
Can you repeat the question, Doc?
What is this? The question is that simple.
Oh.
What is this?
For me, it looks like patient has got a ventricular broad complex Q waves, so it's got a ventricular tachycardia. So it's tachycardia with there's a word now that I wanted to say, but it's of ventricular origin. So the ventricle is contracting at a very increased pace. So it's ventricular tachycardia. Although it's sustained, sometimes we do have in between normal QRS and then it goes on and on again. That's what I think.
Okay. All right, thank you, Janelle. So just to go back a bit, the way the exam is set up, you will need to do spot on diagnosis of ECGs. So this is what is called a Torsades de Poix.
No.
Yes, no.
I actually thought about it, but it wasn't so classic of the turning points. And then I thought either it's ventricular tachycardia, but the turning points are not so classic. Thank you, Doc.
But a Torsades de Poix, it is a ventricular tachycardia, a polymorphic ventricular tachycardia. But unfortunately, for exam purposes, the name that is a Torsades, or if you don't say it's a Torsades, you need to mention that part, that it's a polymorphic ventricular tachycardia. You're not wrong to say it's a ventricular tachycardia because of the broad complexes, but unfortunately, it's one of those where you can't miss it's a Torsades, because if you just stick to ventricular tachycardia, my next question, which would be, what would be your pharmacological management? You won't think about it if you don't know it's a torsades. If you just generalize, because there are many types of ventricular tachycardia, if you get what I mean. So generally, its name it is a polymorphic ventricular tachycardia, but this is a torsades.
Okay.
You can find us another picture, Janelle, and because I do agree with you, sometimes the pictures of ECG, it's not a, they're never really the same. You do see that twisting pattern here, but you can find us another picture so that also other people can see how else it can look.
Okay.
Yes. So so what's your management?
The management of torsades poor.
What's your pharmacological? Let's say the patient is yes.
Okay, pharmacologically, if I go straight to the point, is we treat it with, it depends on the cause there at that point in time. The most common cause is hypomagnesia, but it can be hypocalcemia, it can be hypokalemia, so it depends on the cause at that time. But the most common one we know it's hypomagnesia. So if it's hypomagnesia, then we treat it.
Theater intraoperatively. So how do you manage it? You don't know yet what the electrolytes are looking like and stuff like that. You just get this. So what do you do?
Okay, it depends if the patient is stable or unstable. We use the ABC approach, depending on the stability of the patient. And then if the patient is unstable, obviously is under anesthesia, it's ABC, secure the airway. If it's secured already, 100% oxygen. And then the breathing, we ventilate in the patient. C, if the patient is hemodynamically unstable, and then one is to stabilize the patient. But the treatment of this type of tachycardia, it's an unstable patient. We know it's we need to cardiovert. But pharmacologically, if it's a stable patient, the treatment you can give 2 grams of IV magnesium if the cause is hypomagnesia.
Okay. Perfect. So that is all correct, you know. But then again, let's go back to how to answer for the exam, or how to answer for the exam. So what you've given me is totally all correct. But if then you ask this, I remember especially now with the new method where you use the computer and stuff like that. Try and use as minimal words as possible. So if they ask what is this, if say it's a total, what's your management? It depends where the patient is. Hemodynamically, don't just say stable. What stability are you talking about? So hemodynamically stable or not? If unstable, you would go synchronized cardioversion. If stable, we go magnesium. So just in preparation for the exams, try and answer in point form. But what you said, all of it is correct. And again, a few things where people tend to lose marks. You said would do cardioversion. Remember, that's not complete. You need to mention it, synchronized cardioversion. Right.
Yes, Doc. Thank you so much.
Thank you. So this is a type of arrhythmia, a ventricular tachycardia, but unfortunately you need to know. So as we just said, as Dineo said, premature ventricular complex. So there's a risk of arrhythmia, of which this patient went into an arrhythmia, which it was a torsades de poor, which is a polymorphic ventricular tachycardia, and yeah, the management that Dineo described. Right.
Yes.
Yes.
Yeah, I asked on the previous ECG. So is it like with the torsades, for like if it's spot diagnosis for this ECG, is it fine to say torsades, or can you just say it's a polymorphic ventricular tachycardia? Because it isn't it torsades when you know bana cause was hypomagnesia, or you can just say torsades as a spot diagnosis.
Both of them, polymorphic ventricular tachycardia, because it is polymorphic and it's a ventricular tachycardia, or torsades, both of them are correct. But torsades is very specific. I'm not sure where is it. Okay, let me not give away the answer for the next one. Both of them, to say torsades or polymorphic ventricular tachycardia, you'd get 4 marks for both, whichever answer you put for this one. But if you just say ventricular tachycardia, it won't be necessarily correct. But a lot of these sometimes, if these exams or examiners, particularly for a particular polymorphic that has a specific treatment, they do want you to mention the name of it.
Okay. No, I understand. Okay, thanks.
Because it has a particular, pattern compared to other ventricular tachycardia.
Yes.
But both answers will be correct. Okay. 1 minute or 30 seconds. What's your spot on diagnosis? You go see a 24-year-old coming in for breast reduction. She has that ECG. What is that?
WPW.
Sorry. I think you were correct, but trust your answer. So what is it?
Hi, Doc.
Hello.
It's Madonna.
Hi.
I see delta waves on this ECG. So I think it's Wolff-Parkinson White, Parkinson Wolff-White syndrome. Yes.
Yes. Correct. Beautiful. So what is that? What is Wolff-Parkinson White syndrome? And what are your concerns about it?
It's a pre-excitation syndrome, Doc.
Okay, correct. Let's say you explain to a student, what is a pre-excitation syndrome? What's the problem? Okay. He's totally correct. This is a Wolff-Parkinson White syndrome, which is a pre-excitation syndrome. So what that is, it means there's an accessory pathway from your SA node that bypasses your AV node and goes into the ventricle. Some literature calls it the bundle of Kent. Let's go back to the physiology. Remember when we learned in second year, whatever, the physiology of the heart, your electric pathway goes through your SA node, goes through your AV node. Do you know why it goes through your AV node? What happens in your AV node? why is it important that a normal power, electrical pathway goes through your AV node? Dr. Zoe, tell me, what happens in the AV node that's quite important, that if you don't go through your AV node, you bypass? Okay. Sorry if I pronounce this wrong. Mahlache. Why is it important to go through your AV node? We're talking about second year stuff now, by the way. Khulile? Feel like asking Kakamba again. I like his name. Kakamba.
Okay, hi, Dr. Jesse. So I think it allows for a conduction delay so that the atrium and the ventricles don't contract at the same time.
Perfect. Yes. So that is very important. So with the Parkinson-White syndrome, there's this accessory pathway which does not go through the AV node, meaning that there's no slowing down of the rhythm. There's no slowing down of the electrical pathway. So that puts the ventricle then at risk of arrhythmias. It's important to understand what are the risks with the Wolff-Parkinson-White syndrome. So we said it's an accessory pathway which causes that pre-excitation because there is no delay in your AV node. Now, let's put another question, of which is something we're going to talk about today towards the end. Let's say you have a patient with AF, atrial fibrillation, that you want to rate control, but the patient also has Wolff Parkinson-White syndrome. Which drug should you avoid? Remember the principles of AF management. One of them is rate control. Which drugs should you avoid in a patient with an AF and a Wolff Parkinson-White syndrome, and why? Homotso. Bessie, can you tell us which drug should you avoid in a patient with an AF and a Wolff Parkinson-White syndrome, and why? It's also related to what Kakamba described, the delay in the AV node. Okay. So in a patient, remember when you're trying to rate control, one of the drugs you want to use is things like beta blockers. So in a patient with a Wolff Parkinson-White syndrome, you need to be careful on a patient, if a patient is on beta blockers and there's a Wolff Parkinson-White syndrome, because it means you'll be slowing down the pathway that goes through the AV node, and that leaves the accessory pathway free to stimulate the ventricle as it pleases. That means the patient is at risk of a ventricular fibrillation, because if the importance of that AV node is to avoid the ventricle going at the same rate as the atria. That is to avoid then the ventricle going into a ventricular fibrillation. So it's quite important. So how do you treat a Wolff-Parkinson-White syndrome? So a patient who's hemodynamically stable, treated as an outpatient, catheter ablation by the physicist in combination with the cardiologist is the treatment for the Wolff-Parkinson-White syndrome. Okay, do we all understand? Are we still all here? What's your spot on diagnosis? Case number 5. You're anesthetizing an elderly patient, and then this is your ECG from the beginning. So what is this? Who hasn't answered? Give me an answer. Sinengom, so have I heard your voice? Hello, Sinengom, so. Ayanda, sorry to go back to you. What is this? Luna? Okay, Luna, please give me something. So what is this?
Sure, difficult. I think it's a, oh my God. Let's see the present. My God, I'm not sure, really.
Okay, let's look
It could
at
be
let's look at V2. I think it's showing it nicely. What do you see in V2? Let's look. Can you see my cursor?
yes.
Yes, Luna. Speaking to Luna. Look at my cursor. Let's look at V2. There's a QRS. There's a T.
Yes.
There's a QRS. There's a T. So what is that?
Ventricular, atrial fibrillation.
Atrial fibrillation.
I
Why do
don't
you
see the T wave on that.
Yes. So usually with a ventricular, an atrial fibrillation, you don't see a P wave. And sometimes, especially this is a fast AF. So with a fast AF, be careful to think the T is the P.
Oh.
Because because it's a fast AFM, I think the T is a P. So this is a atrial fibrillation. So what are the principles of management of an atrial fibrillation?
You firstly need to control the rate and try to make it a normal rate.
Okay,
And,
rate
take-
control.
Yeah, prevention of thrombus.
Okay, prevention of formation of the thrombus.
Like you put the patients on anticoagulation so that they don't develop thrombosis.
Okay. What else?
You can do cardio visit
Okay, when?
depending on the whether they're hemodynamically stable or not.
Okay, say that again. So you do cardioversion when?
If they're hemodynamically unstable,
Unstable. Okay, all right. And what else do you have to know about your atrial fibrillation before you cardiovert? And what's the risk of cardioversion for these patients? So what can you quickly do in your theater that can give you go ahead if you can do the cardioversion if you don't know the history? But what history do you have to know about the AF before you cardiovert? What's the risk of cardioversion? Why am I asking? So remember, you need to know how old you, if it's a chronic or an acute AF, as in
oh yes,
chronic, yeah. If it's an AF that's been there for more than 48, 78 hours, there's always a risk of like the thromboembolic events that you talked about. So you
Yes.
need to know if the patient doesn't have a thrombus. Already, of which in a theater setting where there is resources, you don't have to take the patient off the table. Someone can do a TOE, a transesophageal echo, to check if there's a thrombus, and then you see if you can continue or not. What else in the principles of management of an AF have been mentioned?
Sorry, I think yes.
Principles of management of an AF. You said rate control, anticoagulation. What else? What does cardioversion do? So don't forget it. So it's rate control, it's rhythm control, it's anticoagulation. So rate control, rhythm control, anticoagulation. And then in terms of rhythm control, you can use pharmacological or the one you've mentioned, the electrical way of your rhythm control, because your synchronized cardioversion changes the AF rhythm to a sinus rhythm. What pharmacology, someone else, thank you Lynn, for answering. Someone else, what pharmacological management can you give as a rhythm control? And someone else will tell me what pharmacological management you use as a rate control. Let's start with the rhythm.
Digoxin is one of them.
Digoxin. Okay, would you start with that? What else can you give for rhythm control? Let's say you're in theater.
Beta blocker. A beta blocker.
Okay, beta blocker for which part? For the rate control, for the rhythm control?
For the rate control.
For the rate control, yes. For the rhythm control, what anti-arrhythmic can you give in theater? Because remember, digoxin will take. Yes. So you can give an amiodarone bolus and then run an infusion. Because always take it in theater, not in an MOPD setting. what would you do in theater? Let's say the patient is hemodynamically stable. Then you would give amiodarone bolus, 150 to 300 milligrams in dextrose, in 5% dextrose or dextrose saline over 20 minutes, and then rhyme in amiodarone infusion. Good, thank you.
Thank you.
So as she mentioned, rate control, these are the principles of management, rhythm control, anticoagulation. With your rate control, you can use your beta blockers, your calcium channel blockers. Remember, there are IV calcium channel blockers that you can use. And there are fast-acting beta blockers like esmolol that you can use, which are cardio-specific, as opposed to things like labetalol. Then rhythm controls, as she mentioned, pharmacological and electrical management, pharmacological, your antiarrhythmics, and then if your patient is hemodynamically unstable, then you can do synchronized catheterization. And then don't forget to mention anticoagulation because of the thromboembolic event. Okay, before we go on, if you get a patient with a fast AF in theater, why are we going through this? Why do you need to treat it? What is the disadvantage of the thing an AF? Why is it important to treat? Let's say on the table, the patient is getting whatever operation, and then she gets an AF or he gets an AF on the table. What's the issue with AF? Why do you need to treat it fast? Especially if it's not rate control. Because on the table, you don't really worry about the rhythm control much if the patient is stable. Mostly you wanna deal with your rate control. What is your worry? A quick answer before we move on. Dr. Danny Bele, sorry if I didn't pronounce it right.
Hi, Doc.
Hi.
I think we are worried about decreased cardiac output.
Yes, because talk me through an AF, like why would the cardiac output be decreased?
Because the atria are not contracting at a regular rate. So there will be loss of the atrial kick. So that will then basically decrease the amount of blood that will be pumped into the ventricles, and then
Yes, perfect. So that is correct. And that is important because now you're already running all your other anesthetic things that decrease your cardiac activity, vasodilating this patient, you've positioned this patient in whatever way. So if then you have an AF which is not rate controlled on the table, the risk of loss of your cardiac output is very high. That is why it's quite important to manage the rate of an AF. So take a message from this slide is that don't worry about your rhythm control, especially if your patient is hemodynamically stable. Mostly what is important on the table is for your rate control so that you give enough time for your diastolic time for that fibrillating or poorly contracting atrium. So your rate control is quite important. Yes, also your rhythm control, but again, turning it from AF to sinus rhythm without knowing that there's a thrombus, is that risk of thromboembolic event. So rate control always supersedes rhythm control in management of an AS. Okay, I think we are left with maybe 3 or 2 slides and then we finish. Let's check what time is it. Okay. Do this one. Okay, you have a 66-year-old patient. Let's quickly go through this one. You have a 66-year-old with diabetes, hypertension, coming in for emergency amputation. The patient is not looking to go to respiratory distress, edematous. What are your anesthetic concerns and what is your anesthetic plan? I just want you to give me the goals of how you would anesthetize the patient. Don't go in through attaching monitors and all of that. 1 minute, look at that ECG and tell me in point form what would be your anesthetic concerns and how would you anesthetize this patient. Okay, what's your spot on diagnosis? There's lots going on with this slide, but what's your spot on diagnosis? Okay. Komoto, did you answer me? Did I hear your voice? NPC. Maybe I heard you guys, but I didn't know who I was talking to. Okay, who's going to give me something before we move on?
Hi, doc. Okay, so I think the patient,
Who am I talking to?
hi, doc. So I think the patient has a left ventricular hypertrophy using the Sokolov
Say that
formula.
again. Hazel, what?
Left ventricular hypertrophy.
Okay, yes.
So using the Sokolov formula, which is S in V1 and R in V5 or 6. So it's more than 30.
Okay, perfect. That is good, Kakamba. Thank you. With this history, what else do you think is going on? Kulile? Yes. Dr. Tanavela, I see you want to say something. Tell me. With this history, what else do you think is going on? Kakamba is correct. So there's left ventricular hypertrophy. What else? Look at your
Hi.
ST.
I think the patient could be having an anterolateral STEMI. Well, taking into account the history of the diabetes, such patients may have a silent MI. I'm not sure.
All right. So how would you anesthetize this patient? I know how, okay, let me not say what I was about to say, but how would you anesthetize this patient? How would you do this patient? She's coming in for a guillotine. The surgeons are, it will be like 2 minutes. I'm just going to, don't worry, doc, it will be fast. How would you anesthetize and why? Okay, let me say, would you do regional or general anesthetic?
Mm,
Okay, just to move on, most of you guys, I'll say, I'll include myself and say most of us would be tempted to do a regional anesthesia in this patient. But looking at this history, that would not necessarily be a good idea. If you do a regional anesthesia on this patient, you would need to avoid spinal anesthesia in this patient. If anything, if you do a regional, you have to do a very much graded epidural anesthesia. Why I'm saying that? This patient is in trouble already. This patient has these comorbidities and looks like already this heart is ischemic to infarction. So if you do a dense block like spinal anesthesia, you take away that sympathetic drive that has been keeping this patient being able to breathe that fast and in respiratory distress, and this patient will crash. So a patient like this, patient who looks like he's having an infarct, who's already ischemic, in respiratory distress like that, if you take away that sympathetic pathway for the patient, a dense block like spinal anesthesia, you will be in trouble. So if you do a regional, a patient like this, you need to do a graded epidural, but yeah, a very planned out anesthesia, general anesthesia would be a good idea for this patient, with a quick A line so that you can monitor your blood pressures, and then you do a cardio-stable general anesthesia for this patient to go back into a high care setting for monitoring. Yeah. So this is a patient who has a left ventricular hypertrophy, who does not only look ischemic. If you look at the STs, look like there could be an element of an infarction. So this could be a non-ST elevated myocardial infarction. It could be a non-STEMI. So it's a cardiac or non-cardiac again. So your goals in deciding your optimization and which anesthesia you're going to do for this patient will revolve around oxygen supply demand to the heart. So with your induction, with your maintenance, with your emergence, all you're playing around with is oxygen supply and demand to the heart. And then again, what I said, GA versus the regional, a lot of people would go for spinal anesthesia, which is not necessarily a good idea. And then Kakamba mentioned which criteria she uses for left ventricular hypertrophy. Whichever you use, be able to diagnose left ventricular hypertrophy. And what are the implications? Because, like I said, the point with the exam is not for you only to pick up an ECG. You need to know then what are the anesthetic implications, because the question will be either what are your anesthetic concerns, or how would you manage for whatever situation is there. Okay, let's quickly go through the 3 slides that are left. What is this? And what is the management? Quickly now. Yes, Luna, tell me something.
Supraventricular tachycardia.
Supraventricular skills, yeah, perfect. Management, 2 lines. Management,
You give adenosine
if,
6 to 12 milligrams.
okay, if hemodynamically stable,
Oh yeah, okay.
and then if not, what do you do?
Cardioversion.
Synchronized cardioversion. Okay.
Yeah.
What is synchronized cardioversion?
When it's synchronized, it has to, I forgot. I think it has to do with it has to do with when the QRX complex. I'm not sure. I'm gonna lie.
Okay. So remember, when you give electrical shock to the heart, the machine is a machine, doesn't know what is happening really to the heart. So what synchronized, and when you do electrical shock to the heart, what it does, it does one thing, whether it's defibrillation or cardioversion, it depolarizes the myocardium. Ne? So synchronized cardioversion is you depolarizing the heart on the R wave that is depolarizing at the interval where the heart would be depolarizing on the R wave. Why it's important to do synchronized cardioversion when you need synchronized cardioversion versus defibrillation? If you do not synchronize the shock of the heart and you give the depolarization or the shock during the repolarization phase, that is your T wave, you have what you call an R on T pattern. That will push your ventricle into ventricular fibrillation. Because remember, the repolarization phase of your cycle is the most vulnerable. It's the most time where the myocardium is more vulnerable to arrhythmias. So if you depolarize then on a T, that is on the repolarization cycle, then you are going to push your heart into a fibrillation, a ventricular fibrillation. So it's important, if there is a pulse on a patient, you never defibrillate. You do synchronize cardioversion to swap whatever rhythm to sinus rhythm. Always remember that. If there is a pulse, you never defibrillate, because people always think it's the same thing. You just defibrillate the heart, like it shows on these TV things, Grey's Anatomy, there's asystole, and then you put the pads on. If there is a pulse, you do not defibrillate, you cardiovert. And the cardioversion needs to be synchronized so that you don't push a patient into a ventricular fibrillation. You understand? Luna?
Oh, sorry, my mic off. Yes, I understand.
Makes sense now. Okay, that is what it is. So practically, how do you see it? If you are the one now you're going to cardiovert, when it is ready, the machine, the paper strip will have a dot on top of the R's. If there are no dots on top of the R's, your machine is not synchronized yet with your with your sorry, my son, with your with your heart rate, that is with your QRS of your patient's heart. Just give me a second. Go to dating, baby. Dating. Okay, sorry about that. We're almost finished. I hope it makes sense. So clinically, when you do it, there should always, if you're going to do synchronized catheterization, there should be a dot on top of your R wave. Okay, next one. So remember the actual definition of a reciproventricular tachycardia, the rate needs to be above 160. If it's below that, it's still a sinus tachycardia. And how you differentiate whether it's ventricular or it's still supraventricular, that coming from the atrium, it always has to be narrow. And then the management, Luna talked about it, the pharmacological and the non-pharmacological, and the pharmacological, the adenosine. Okay. What is this? Can I have a male to answer this one? What is this? Guys, come on. How many guys are in this? Thank you.
Hi, Doc.
Hello.
I think this is a polymorphic ventricular tachycardia.
Okay. So this is a ventricular tachycardia. Is it mostly polymorphic or monomorphic?
It's mostly monomorphic, but at V2 there's a change in the
Yeah. Okay. Perfect.
pattern.
So how do you manage this?
It depends if there's a pulse or if there's no pulse.
Okay.
Hemodynamic.
Usually with a ventricular tachycardia, usually is there a pulse or no pulse? The tachy?
I didn't hear you, Doc.
So with a ventricular tachycardia, is there a pulse or no pulse?
There's no pulse.
Okay, what is this? Before we go on to management, let's go on to the next slide. What is this?
It's ventricular fibrillation, Doc.
So usually this is the one with no pulse. Usually
No.
a tachy won't have a pulse. This is why usually a ventricular tachycardia, the management is synchronized catheterization. Basically because there's usually a pulse. Yes, it's a fast pulse, but usually there's a pulse. This is the one usually where there is a pulseless electrical activity, the fibrillation. So what is the difference in the management of these two? This one, you do synchronized cardioversion. This one, what do you do? What's the management here?
You defibrillate, Doc.
Okay, perfect. You defibrillate. But what is the other management, which is also important that you can't miss?
So you manage the patient according to the ACLS, the shockable rhythm algorithm. So you shock, you compress, and then you rhythm control using your pharmacology.
Yes. Yes. So it's very important with the fibrillation. People always stick to you defibrillate. You need to mention, because this is a pulseless patient. You start, your CPR needs to be part of your management. You start with your CPR while you're preparing to defibrillate your patient. So CPR is very important. Remember, research has shown that two things that are very, very important or show better prognosis in a patient who arrests: early CPR and early defibrillation of those patients. Let alone all other things you do when you resuscitate the patient. Those two needs to be done very early, because it has been proven that delayed CPR on a patient who's pulseless, the chances of poor prognosis is quite high. So when you answer this question, I'm not sure I want to say they usually a bit tricky when they put it, because it's not only defibrillation that they want, because they want you to bring up that you understand that it's a pulseless patient. So CPR needs to be part of the management of the patient on top of, because only shocking a patient who is pulseless, chances of good prognosis are poor. So it's both CPR and defibrillation of the patient. Thank you for that. We've talked about it. Okay, last question. I want the same person was answering, or another male. Sorry, am I being sexist? But yeah. What is the physics of a defibrillator and how does it work? This is not an unfair question. I think I was asked, I wrote the DA, I think in 2016, I think I was asked this in the written. In our days, the DA, they're saying they're incorporating it to be similar to a part one. So I'm sure something like this might come up in the current diploma now. So how does a defibrillator work? Okay, this is the last question. So you guys can give me suggestion. Who hasn't talked, who needs to give me an answer? Kakam, you can volunteer someone to talk.
Okay, we can ask Dineo or Dr. Ndlovu.
Okay, Dineo has said something. Who hasn't talked? Dr. Futane, have you said something?
Yeah, yes, I've said something, but I would be lying in physics. I'm not sure.
Okay, call a friend. Who do you want us to give the answer?
I think Dr. Ndlovu was not at all.
Who Dr. Ndlovu?
I don't know anyone else talking. There's Nyan.
Okay. Okay, let's we won't go deep into whatever, but it's quite important. I think we understand how it works. But on top of that, what I said to you guys, I was asked this like years ago, and now they're changing the way they're asking. They're preparing for the DA to be similar or to be a part one of part one. But okay, a defibrillator, remember, it delivers electrical energy to the heart. So the goal, like we said before when we were explaining the synchronized, is to depolarize the myocardium completely, with the aim that this will revert it to a sinus rhythm. So a defibrillator then has to be able to deliver the electrical energy. It has to have some form of power supply. Maybe let me show this circuit. So it has to have some form of power supply to charge the whole circuit. And then it has to have some form where the energy, it is stored. So remember the physics we learned when we learned physics in high school. Energy is stored in a capacitator, so the energy to be stored there. So in the terms they use, so you charge the capacitator so that when it is needed through the inductor, then you discharge the energy in forms of joules to the heart. So it has to have a power supply, capacitator, and inductor, and a set of pedals. So you put in energy into your circuit through your power supply, you store your energy, that is, you charge your capacitator and store your energy, and then energy is then converted and then discharged through your pedals into your heart. So that is why the part I was talking about, it's important for you to press the right button. Are you going to synchronize or are you going to just defibrillate? Because the machinery itself will not detect what is happening. So you're the one who needs to direct it, whether it's going to synchronize or defibrillate. Because all it's going to do is deliver energy. That is, all it's going to do is depolarize the heart. Whether it depolarizes the heart during the T wave, which that will cause an arrhythmia, or it depolarizes the heart during the R wave, which will then cardiovert the heart. Quite important. All right. I think that was our last one. Any questions before we close the session?
Yeah, sorry, Doc, I just have one question. How do we now differentiate between a PVC and a premature atrial contraction? I'm not clear on that one.
Let's go up in the next slide. So a premature atrial contraction, because it's atrial, it will have a P. But how do you know it's a premature atrial contraction? The shape of the P will be different from the normal QRS complex that you have in your ECG, right? Then how do you differentiate between a premature atrial contraction and a premature ventricular contraction? The premature ventricular contraction will not have a P that is followed by a QRS. Because remember what the P is. So if something is, its source is ventricular, they will not be a P. You understand?
Yes.
Yes. So a premature atrial contraction, there will be a P followed by a QRS, but the P will be slightly different from the P of the normal QRS complex. Sometimes you do notice that if it's a premature HL too broad to say it's a ventricular rhythm, but even the QRS complex will be slightly different from the normal one, but mostly it's the P that is different, because remember, what is a premature HL contraction? Most of the times it means it's not from the SA node, it might be from somewhere in the atria. That means then the shape of your P will be slightly different. Usually it's a smaller P than compared to the other normal P's. But to differentiate a premature atrial contraction from a premature ventricular contraction, the PVC will not have a P. So the complex on its own will be broad and will not be preceded by a P.
All right, makes sense. Thank you.
Thank you, guys. Good luck with the exam.